Good afternoon, everyone, and welcome to session number 5 of the American Liver Foundation's Liver Health Echo Program Cohort number 2. Today's focus is pediatric MASLD, early detection and management, as well as a program overview. We're thrilled to have you join us today. I'd like to begin with a warm welcome to all of our participants. We're excited to kick off this session, and we look forward to your engagement. Please state your name and the organizations you represent in the chat. We're honored to have a distinguished speaker with us today. But before I introduce her, I'm going to talk a little bit about the American Liver Foundation. The American Liver Foundation is the nation's largest nonprofit dedicated to liver health. Our mission is to educate, support, and advance research. Key programs include our patient registry. The patient registry is a national initiative designed to collect data from individuals 18 and older in the US with any form of liver disease. Its purpose is to help researchers better understand liver diseases, evaluate the effectiveness of current treatments, and improve patient outcomes. We also have the Think Liver, Think Life program. It's ALF's flagship public health initiative focused on MASLD, MASH, and liver cancer. I'll go ahead and introduce our speaker now. Please join me in welcoming our overview and case study presenter, Dr. Batul Kaj. She's an assistant professor of pediatrics at Northwestern Feinberg School of Medicine and an attending pediatric transplant hepatologist at the Ann and Robert H. Lurie Children's Hospital of Chicago. Dr. Kaj is a board-certified pediatric gastroenterologist and transplant hepatologist with advanced training in intestinal rehabilitation, hepatology, and GI liver transplants. Her clinical interests include caring for children with intestinal failure and short bowel syndrome, hepatobiliary disorders, and the management of pediatric liver and intestinal transplantation. Her research interests include consortia and collaboration-based investigation of rare diseases, as well as clinical and quality improvement projects in pediatric intestinal transplantation. She also has a strong interest in medical education and mentorship. Dr. Batul Kaj, you can take over the slides from here.
Thank you. Can everyone hear me okay?
Yes, we can hear you.
Okay, perfect. Sorry about this, guys. I was just running a little bit late with a patient, but I will, let me see. I will make sure you guys can see my slides. And is that working for everyone? Beautiful. Okay, well, let's get cracking. So we are going to talk a little bit today about what was formerly known as fatty liver disease in children. We now lovingly call this metabolic dysfunction associated steatotic liver disease, which I will tell you is a mouthful, and like it takes some practice to say that over and over again. What we're really going to focus on today is kind of the detection and management of pediatric MASLD, and then we'll think through a case study that is actually a patient of mine who I recently saw. So this is just kind of our agenda for today. And I want to focus quite a bit on this recent set of guidelines. So this is an ASLD, so the American Association of Liver Diseases writes practice statements, and we kind of tend to try to follow those because they are uniform, kind of well-studied guidelines. And so this is a statement on management of MASLD in children. Dr. Xanthakos is a friend of mine and is one of the main researchers in this area, actually. So a lot of her work will be cited throughout this talk. So just to start with, when we think about MASLD in kids, right? So we know that there are a number of different factors that contribute to the pathogenesis of MASLD. So there are some, and you know, there's varying levels of data that support all of these different factors, but we feel fairly confident that these factors listed out here in this graphic are important factors in the development of MASLD in kids. So it looks like there are some people in the waiting room. I'm just admitting people. Is that okay? Okay, so prenatal and sort of epigenetic factors, these are factors in utero usually that are affecting the fetus. Some of the things that have been linked to the development of MASLD in children are advancing maternal age, maternal obesity, the quality of the nutrition of the mother, hypoxia and smoking in the mother, diabetes, and intestinal dysbiosis, which is an imbalance in the microbiome of the mother. These are some things that have been linked to the development and progression of MASLD. There are definitely some genetic variants that seem to contribute to a worse outcome. So certainly the way that we think about these genetic variants, the ones listed here are sort of split into steatosis risk, which is just the fat deposition in the liver, and then the fibrosis risk, which is, is that steatosis actually going to then turn into scarring within the liver? And there are distinct genetic variants that are associated with progression in children. The PNPLA3 is one of the kind of big hitter ones. We often test for those in some of our kids because of recognizing that when children have a mutation or a variant in PNPLA3, they tend to progress a little bit faster through the stages of MASLD. There are, of course, postnatal environmental exposures, right, that are arguably the most important. So, right, you can have the epigenetic in utero factors and all the genetic variants and still not develop MASLD if you live a perfectly healthy life with no added sugar. But sadly, I think none of us really have that. So the certainly added sugars and processed foods contribute. Dysbiosis has been shown to contribute, and then there are certain endocrinological factors that we think also contribute. When we think about diagnosing MASLD in children, really the current guidelines ask for two things. One is that you have steatosis in the liver that is determined either by imaging or biopsy. And often when we do a biopsy in these patients, it's really like there are lots of reasons why you might have fat in the liver, but when we're thinking about specifically MASLD, it really has to be more than 5% of the liver that is involved in this process. And then in addition to that, we typically think about, to sort of pull the whole diagnosis together, there's usually some other cardiometabolic risk factor or something else going on. So for example, pre-diabetic HbA1c, maybe they have high blood pressure, maybe they're obese or overweight. And so there is usually steatosis combined with something else that helps us to kind of make this diagnosis. Oftentimes, I'll just tell you in practice, right, most of the children that I see in clinic arrive in clinic because they have elevated liver enzymes in the setting of being either overweight or obese. And so it is our job then to tease out, is this enzyme elevation from MASLD or is there something else going on? And we'll talk about that a little bit in the next slide. And I think that a really important point to make here is that while MASLD in children, sadly, has become probably one of the most common reasons that we see, probably the most common reason actually that we see as a cause of liver enzyme elevation. There are lots of other things that we still have to think about in kids, particularly because, right, the risk of missing a diagnosis in children is high, right? So we still do test for other causes of not just liver disease, but also steatotic liver disease. So let's think this through a little bit. So this is a really nice graphic taken from the paper that I had talked about by Dr. Xanthakos. It really sort of tells you that there are lots of reasons why you can have fat in the liver of a child, okay? So by far and away, the most common cause, as you can see over to the left side of this graphic, is MASLD. So as I was saying, you make that diagnosis by steatosis that you have on either imaging or biopsy, and then a metabolic risk factor, including some of those that are listed there. Those are by far and away the most common causes of steatotic liver disease in children. But then you have the other ones, right? So the other ones that we have to think about are, could there be drug-induced? Is there a viral cause? Could this be Wilson's or celiac disease? So celiac disease, interestingly, can present with elevation of liver enzymes where you might actually see steatosis on their biopsy. So that's something to think about also. So there are those diseases in that red box right there that we sort of think about when we're doing our initial screening testing. And then monogenic diseases or inborn errors of metabolism, this is very specific to pediatrics. This is, our adult colleagues don't think about these very often. So these are genetic or metabolic conditions that lead to dyslipidemia or errors in lipid metabolism that can end up with fat in the liver. That is may end up looking like clinically steatotic liver disease, similar to MASLD, but the genetic basis is different, and there may be some elements of management that are different than where you're not focusing as much on diet and exercise as much as you are about sort of trying to think about what medications might modify the risk factors otherwise. Thankfully, we don't see as much in children the MET-ALD, which is the metabolic associated steatotic liver disease in combination with alcohol consumption. It isn't impossible. We do have some, teenagers that drink and can run into trouble, but this is, I will say, incredibly atypical, incredibly rare. We then have cryptogenic liver disease with steatosis. We typically don't see very often at all. And then, as I was saying, alcohol-related liver diseases we see very rarely in pediatrics. So then it comes to the diagnostic evaluation. So when we meet these patients in clinic, what are we really thinking about? So as I was mentioning, typically the patients get to me because they have elevation in the ALT or AST, often both, or sometimes because they have imaging done for other reasons that shows up this kind of echogenic appearance of the liver where there's a concern for steatosis. So those are typically the ways that folks will get to me, at least in clinic, and get to our liver clinic. And then when we think about how do we put them into, what do we do with those patients? Well, to start with, the medical history and the physical exam is incredibly helpful, right? So the medical history is really going to involve a pretty detailed diet history as much as you can. You're going to screen for alcohol use, particularly in children above 12 years of age. You're going to check for family history of any either early onset liver disease in relatives of the patient. You're going to think about liver diseases in general in the parents. You're gonna think about, what other medical conditions does the patient already suffer with? Do they already see a specialist for hypertension? Do they already see a specialist for elevated blood sugar? Things like that. The physical exam is actually very helpful. So while I will say that often in a patient who is with obesity or overweight, you may not get a great abdominal exam as far as organs go. It can often be difficult to feel for hepatomegaly, for example, on exam, or it can be just because of the depth of adipose tissue. So that can be problematic, but there are other things that you're going to be looking for. Is the patient jaundiced? Is their skin yellow? Are their eyes yellow? Are there any, another one I like to show often in patients is something called acanthosis nigricans, which is in the back of the neck, a darkening of the skin. Or under the arms. And that acanthosis can be a marker of insulin resistance and hyperglycemia. And so while it maybe doesn't matter particularly for the liver disease, what it does help us with is to say to parents and the kids, as you work on these diet and exercise changes, as these things improve, this darkness will disappear. And so they often will look for that when they come back for their follow-up visits, and they'll tell you, oh, this looks darker than it was, or this looks lighter than it was before. And so that can be a nice, a helpful marker also. It's also really important for us to remember that in thinking about the cardiometabolic risk factors, it's very important to document in children, not just the blood pressure, but the blood pressure percentile. We, in general, in pediatrics, which is different to adult medicine, we worry about percentiles much more than the individual numbers. So when we think about growth, we think about growth percentiles. Where is this patient on the range of acceptable growth in terms of percentiles? Similarly with BMI, we don't use the BMI itself, we use the BMI percentile, or the weight for length percentile. It's the same thing for blood pressure. So really, when we decide a kid is hypertensive, it's based on where they are on their percentile of accepted range for that age, okay? So then we get to the lab evaluation, and this is kind of a running joke that we have in hepatology, which is that you can come into a hepatology clinic visit for any reason and go home with a bunch of lab tests. And the problem is the elevation of liver enzymes is incredibly nonspecific and can be caused by a number of different things, right? And so and most liver diseases in the early stages typically are not associated with any symptoms. And so we often do end up running quite a bit of testing up front to make sure that we're not missing something as a cause of elevation of liver enzymes. So what do we typically do? Well, a full liver panel, which would include not just the liver enzymes. In addition, we do the gamma glutamyl transferase, the GGT. We also like to look at total and direct bilirubin, which I will tell you in my experience in MASLD, you typically, you're allowed to have an elevated ALT and AST. Sometimes the GGT might be elevated, but it's very, very, very rare to have a bilirubin elevation related to MASLD. So if you're seeing a patient that you think has MASLD based on maybe the cardiometabolic risk factors and elevation of liver enzymes, but you notice that bilirubin is elevated, you start thinking about other causes for sure in those cases. A CBC can be helpful just to get a baseline white blood cell count, again, hemoglobin, hematocrit, those things. An INR and PT, those are helpful for understanding, is there liver synthetic dysfunction associated with this elevation in liver enzymes? If you have a prolonged INR in this context, it's not likely to be MASLD because we don't see that often. So when you start to see a prolonged INR, you want to start to think about other causes of liver diseases. We always send all of the viral panel just to make sure that we're not missing something there. We send the autoimmune markers. I will say that the ANA is often positive. I want to say most pediatric studies cite around a positivity rate of the ANA around like 50-60% of cases of MASLD. And so the ANA by itself doesn't matter, but it's the other antibodies that can be helpful when you're thinking about autoimmune hepatitis. And then we test for other things too. Alpha-1 antitrypsin will send, Wilson's testing, celiac, as I talked about. And this is helpful to do in often the initial visit, because that way you can sort of get all of that done. And if it's all negative and you feel confident that now we're very specifically at a point where we can say this is most likely pediatric MASLD, you can really then sort of target that management strategy and just really talk about those things and not worry too much about what am I missing, because you've done it already. We do also think about cardiometabolic risk factors. So oftentimes, when the patients are referred by their primary pediatricians or their primary care providers, they often have had the lipid profile done. And so you can use that in your diagnostic criteria. But if they haven't had this done, we usually send those as well. So a lipid profile as well as looking at glucose metabolism, typically with a hemoglobin A1C. This is just, again, making the same point, which is that we, for the most part, we are dealing with the horses, which are in this setting. Most of the time, these kids end up getting diagnosed with MASLD, but you do sometimes still have to look out for those zebras that sometimes will be thrown into your MASLD clinic. And so we do just make sure we check for all of those things in all of our patients. Another word on the zebras. So there are some very rare genetic conditions, the inborn errors of metabolism that we talked about, that can contribute to steatosis of the liver and sort of that steatohepatitis. One of the things that has been on the radar a bit more recently is called lysosomal acid lipase deficiency, the LALD. We think about this particularly in kids that seem to have sort of quite rapidly progressive disease or quite significant steatosis or inflammation on their either biopsy or according to their labs. And we do think about this in the early onset conditions. And so we will send genetic testing for this, and it can be modified. So you can actually give back the lysosomal acid actually to try to help treat this condition, which is what I was getting at earlier, is that it's a slightly different approach than in these kids than it would be in a sort of straight pediatric MASLD otherwise. There are also some lipodystrophy syndromes that are genetically inherited. I think whether the lipodystrophy syndromes may not have a specific treatment option, but I think it just does help to set expectations a little bit, where you do what you can with diet and exercise, and you kind of you expect perhaps that their steatosis won't disappear completely, but that you can get perhaps the information that's related to that under control. And it can be helpful to know, right? Lipodystrophy syndromes often are associated with changes in kind of the muscular tone and muscle weakness. And so, right, it can just inform how you're advising people to do exercise, right? Like if you're telling them go on the treadmill for 2 hours a day every day, and they have a lipodystrophy syndrome, that's not particularly helpful advice, right? So it can just help to tailor the advice a little bit better. And then there is something called lipoproteinemia. There's also a version called alipoproteinemia. So it's either low amounts or none at all of the lipoprotein. And it's a genetic condition that changes the metabolism within the liver of fats. And again, can present with steatotic liver disease. And helpful to know just again, in terms of being able to speak to the disease progression a little bit. These things I will say are rare though. So most of the MASLD that we see is the kind of metabolic dysfunction related MASLD, related steatosis versus all of these kind of genetic conditions. Again, just to sort of think about when do we really think about the inborn errors compared to like the more common pediatric MASLD that we see is in kids who present at a younger age. They often have a normal BMI or a kind of lower degree of kind of overweight. Often the patients that we see with pediatric MASLD are in pretty high percentiles as far as their obesity and overweight goes. And so these are, we almost think of them as being like the lean MASLD kids. Typically the AST is a bit higher than the ALT, and triglycerides and cholestatic markers can be elevated also. There's often a family history of similar diseases. Sometimes the parents may be consanguineous where there's some shared genetics, and that can be a factor. And then the other thing is, you may not come to the diagnosis until you try a bunch of things as far as lifestyle modification and feel like you're not making progress. And again, that is speaks to just setting expectations with this. Many of these conditions, the inborn errors of metabolism in the early stages can be associated with other things like low blood sugar, neurological symptoms. Maybe they have other anomalies or other abnormalities in other systems. And that just gives you a sense that there's something else going on here, some genetic underlying disease. Hepatosplenomegaly is what HSM stands for, and that also is not actually very common in straight MASLD. So when it's metabolic dysfunction associated, you almost never get hepatosplenomegaly actually. So when you see that in combination with steatosis, start to think about inborn errors. I won't spend too much time on this, but I think the key thing is that you want to try to be as specific as you can up front with the diagnosis, right? And so if you are making a diagnosis of MASLD, you want to really try to make sure that you've thought about, does this patient have risk factors for any of these other conditions? Could there be some other liver disease going on? And so usually by the time they've had the first 1 or 2 visits with the hepatologist, we usually are able to get to a point where we say, okay, all of the other workup that needs to be done has been done, and we've sort of thought about all these other things, and we can now focus on straight MASLD management. Which gets me to my next slide, which is that we are doing a whole lot of different things for pediatric MASLD now. By far and away, the first-line therapies remain lifestyle modification, so diet changes and exercise. Now, those are incredibly hard to accomplish in the best of cases, but you try getting a teenager to exercise more and eat better, that can be incredibly challenging to do. And I think often the families come to us in a state of exasperation of like, hey, I've told this guy he can't have soda 4 times a day, but he won't listen. And so it's really, I think it's hard to do. And I'm going to talk about that a little bit more in detail in a little bit, but I just want to kind of draw attention to the different arms of, how we think about managing MASLD. So the tier 1 support, right, is exercise interventions, diet interventions, making sure you have a hepatologist to kind of manage the liver enzyme piece and just make sure there's, with all the things we've talked about. And then cognitive behavioral interventions can actually be really helpful also. And there's a lot of good studies in pediatrics to say that CBT, cognitive behavioral therapy, can be helpful in just modifying eating behaviors. And so while in an ideal world, everyone that gets a diagnosis of MASLD would get CBT, we know that that's not always, just resource-wise, not always possible. But we do recognize that works well. And then the additional support, if you are doing those first-tier interventions, you're kind of making sure they don't have other liver diseases, and you're just not making progress, then we really start to think about other things like the new medications that help with obesity. Although there are no specific treatments of MASLD we'll get into in a second, we know that anti-obesity medications, likely the weight loss associated with those medications, can also be very beneficial for the liver diseases. And so definitely there's there's room for medications in this realm. Bariatric surgery, we definitely do use from time to time in children. We have actually a pretty robust program here at Lurie Children's for that. And with careful selection of patients, right? The patients who have severe obesity and have, greater than 2 cardiometabolic risk factors, and are struggling to maintain weight or weight loss, at least on the typical interventions, are usually referred. There's got to be some psychosocial support. I think often, I have found recently in my teenaged patients that there's often concomitant mental health issues. So whether it's depression or anxiety that then leads to changing your eating behaviors, that can contribute to obesity and this problem also. And then just all of the specialties, right? Endocrine can also be really helpful when it comes to some of the inborn errors. So to keep, my slides are frozen. Oh, here we go. So when we think about nutrition management, right? And, it's easy to say, hey guys, just eat better. But what does that actually mean? So I think the first step really has to be evaluate the dietary habits of each individual patient, because you can't really give advice until you know what they're doing now, right? So that is always the first step, is really understanding what exactly are they eating now and what are the things that can be modified. We try to be as age appropriate as we can with both, with our nutritional recommendations. So the fruits and vegetables piece is big and often a problem in kids. And so you can really think about dietary modifications related to the patient's age. Like if you cannot tell a toddler to eat vegetables 5 times a day, it just isn't going to happen, right? So you have to be a bit more creative about it depending on the age. It's so much more helpful to have a registered dietitian involved. Most practices that have specifically MASLD clinics, like we do have a dietitian embedded into our clinic, and so we do have our dietitian see most of our patients whenever she can. Added sugar reduction is such a key factor. I cannot express this enough. I cannot tell you how many patients come in and say, well, we drink juice because it's, fruits. And then it's never occurred to them to look at the added sugar component of those beverages. Added sugar is a real problem, I think, in the Western diets, particularly in the States. And I think one thing, if you take anything from this, it's really encourage your patients to look at the added sugar components of the ingredients labels and the calorie labels, because that's often hidden and people don't realize actually how much that contributes. Unfortunately, there isn't really a specific dietary intervention that has been proven to work in the majority of children. We have to do this and we have to think about the diet, but it's not entirely clear still what works the best and what works most consistently in terms of dietary advice. I do think added sugar feels to me anecdotally like the best approach, or at least a kind of a key approach, but there's lots of other ways to try to get to that. The other thing I think that is really important is that when you're giving diet advice, you really should be giving dietary advice with the lens of the patient's culture, socioeconomic, and psychosocial background, right? I mean, like you, again, can tell people, go to Whole Foods and buy, fresh organic vegetables. But is that accessible to all people all the time? No, right? In fact, it's likely not accessible to most of our patients. And then culturally also, right? Like there are certain cultures where food is a big part of the cultural, the kind of the family experience and the cultural experience. And so it's less in those instances saying don't skip meals, but just here are some ways to modify the food that you're already eating. And so paying attention to all of those factors can be really helpful to just kind of create a customized plan for the patients. Physical activity, again, difficult in children because convincing children who otherwise feel well to do more exercise can be problematic. What I really try to do with my patients is keep it light and easy. So you really don't want this to turn into you need to go to the gym 7 times a week, right? Like that's not what's going to work in kids and even teenage patients in adolescents. It needs to be as fun as possible, right? And we know there is data to support that when adolescents and kids are doing exercise in group settings, that tends to go better. They have to be age appropriate. You have to take into account the neighborhood that the patients are living in. You can't say to them, go run around the block if they're living in a block where the parents don't feel comfortable or safe to allow the children outside. So again, it's really just about getting to know these patients, understanding their individual circumstances, and then trying to be a bit mindful of not just giving bland or generic statements about go use the treadmill for 20 minutes 7 times a week. It's what do you have at home? What do you have access to? So what I often will say to families is, I always ask about the safety of the neighborhood that they live in. I always ask, is there any equipment available to you in the home? Do you have any access to gym memberships, or would that be a consideration? I always encourage families to look at the school district that they're in and find out from school what opportunities there may be for after school sports, or like weekend park district engagements that may be a little bit more affordable. So we really try to think about all of the things that are available to children to just get them moving. Another favorite thing of mine from a physical activity perspective is when I have patients who video game a lot, which, by the way, is every patient ever. The patients who like to sit and or are sitting for a long time playing video games or using devices, I'll say that I won't say you can't do that anymore. I'll say you'll set an alarm every 10 minutes while you're doing that. And every time the alarm goes off, you will stand up, walk around your living room, and then come back and sit down. It just breaks up the monotony of being sat still for all of that period of time. The other thing that I'll tell families to sometimes try is to negotiate with their kids so that kids can earn 10 minutes of video game time by doing 10 minutes of exercise. And so we sometimes will have little strategies like that just to kind of encourage children to get up and moving a little bit more. Does all of this work? Does lifestyle modification work? Well, the truth is, in pediatrics, it actually can in many cases. So about a third of children get better completely just with lifestyle guidance. So just improving their diet, improving exercise strategies do improve in about a third of patients. So we take the biggest set of data that we have was something called the NASH network, the NASH CRN. We had about 500 kids followed over 2 years that were getting treatment in pediatric MASLD clinics. We monitored changes in ALT, GGT, and their histology over time. And after 1 year of standard care, which was basically diet and lifestyle interventions in some of the ways that we've talked about, 22% of children with MASLD showed an improvement, and that number actually increased to 31% at the 2-year mark. But you could argue that this is still, we still have a lot of work to do here. That's still only a third of patients, right? So yes, this is working in some patients, but 2/3 of patients where additional interventions are needed. Interestingly, there are a percentage of patients actually that had worse liver enzymes, despite the fact that they were getting this standard of care advice on diet and lifestyle modification. I think partly, to me, what that speaks to is that we're probably all doing things a little bit differently. And so it's not necessarily we're all picking the most effective strategy to do diet and lifestyle modification. And this NASH CRN was studied across a lot of different centers. And I think the second thing is, right, that the same approach doesn't work for every patient, and which is why the being as detailed as you can with their history and understanding individual patients is so important. This is a sort of a slide just to sort of say there isn't really a specific medication that definitely works to improve MASLD, nor that is approved for MASLD in pediatrics. We're always a little bit behind in pediatric care when it comes to medications that get approved. But at this moment in time, there is nothing specifically that we can offer the patients that we know will help 100% of times. There are some folks that will come and say, is this herbal supplement something I should be taking? You have to be careful with some of these because they are not well regulated, and so there can be components of these herbal remedies that may in fact give you liver toxicity, and so that brings in a layer of complexity. So I often will say, unless it's something that really feels like it's harmless and has nothing in it but plants that I know of, I usually say to try to avoid most of these supplements. Weight loss medications, we'll talk a little bit about this. So, there's so much buzz now about these GLP-1s, and there are lots and lots of adult studies with MASLD and MASH. And just to kind of say out loud, MASLD is metabolic dysfunction associated steatotic liver disease, which is the overall umbrella term. MASH specifically refers to patients who have fat in their liver as well as inflammation. So it's steatohepatitis, okay? So many of these medications, the GLP-1s especially, they are approved now for the treatment of obesity in children. Insurance coverage, I will say, is still a problem. Most of our patients, even above the age of 12, who meet criteria for this therapy may still not get the treatment covered, which is highly frustrating, but we do know that they work. And I think medications that are effective for weight loss likely are effective for MASLD. We just don't have enough long-term data to be able to say that, but it is likely that over time, as we are using these medications more in pediatrics, we will see that there is, I suspect, an improvement in their MASLD as well as their obesity. Couple of things just to quickly say: the liraglutide and semaglutide are the ones that are indicated in children. There are medications being used off-label for weight loss that are not technically, not FDA approved for weight loss, but that do seem to work well. Metformin, we often have patients on. And this can be helpful also when they have pre-diabetes or kind of that diabetic range of HbA1c. Topiramate, I see some of my weight loss colleagues will use this from time to time. It can be helpful for kind of suppressing appetite. And some of these other listed medications we don't use as much. We know that there are medications that treat ADHD, the stimulants that can reduce your appetite significantly and contribute to weight loss. But they also are stimulant medications, and so used judiciously for this indication. But certainly liraglutide and semaglutide are going to be the biggest ones I think that we end up using. This is again just some data to say that in adolescents, these GLP-1s have been shown to be helpful for weight loss specifically. So when us liraglutide and semaglutide actually used in children, so as we mentioned, age above 12 years, significant overweight or so really severe obesity, and then the important thing is you still have to do lifestyle modifications. So you can't just, prescribe this medication and send them on their way. They still do need frequent check-ins with diet and lifestyle, diet and exercise modifications as well. I want to just spend a couple of quick moments thinking about metabolic and bariatric surgery. So we do in pediatrics, we do offer bariatric surgery in some patients. Where we typically think about bariatric surgery is when they have to be above 12 often, with a very high BMI. So if you remember, I talked about percentiles. We really talk about a BMI above the 120th percentile of the 95th percentile. So what that means is not only have you reached the 95th percentile, but you've gone 120% above that in terms of your BMI. So that is severe obesity in children, and often with comorbid conditions. So usually 1 or 2 is enough. And most of the time when you're at a BMI range of 120th percentile of the 95th percentile, you usually are having at least 1 or 2 other cardiometabolic risk factors. We do definitely think about bariatric surgery for those who have significant fibrosis. You have to be a little bit careful if they've already developed cirrhosis, though. So cirrhosis is the end stage of scarring of the liver. That can be a little problematic when you're doing surgery on those patients, just because it increases your surgical risk. So just in the interest of time, actually, I'm going to keep moving here. So just kind of the summary statement is that there are anti-obesity medications I think can be helpful for MASLD. Likely we will have more data to support their use for MASLD specifically, but the likelihood is that the same things that are helping us with weight loss are going to be the same things that help us with MASLD. And I'll stop there for a brief second before we jump into the case study and just see if there's any questions. And I should be able to run through the case fairly quickly, I think. Sydney and Isabella, just give me a thumbs up if you want me to just keep going. Okay, sounds good. All right, so this is actually a patient of mine who gave me a lot of sleepless nights, I'll tell you. So I just want to talk you through this. So this is a 12-year-old boy. He presented initially to me with obesity, hypertension, and a concern for snoring. And it was a patient who had initially had an ALT and AST, so his liver enzymes were sky high, like in the thousands range. Okay, so that already when you're a hepatologist and you see an ALT of 1,000, you're already very interested. But what was interesting about him is that this was in the setting of obesity as well as cardiometabolic risk factors. So his A1C was like approaching the kind of upper range of normal at 5.5. Anything above 5.7 would be considered pre-diabetic range. He had a high cholesterol level. He had a low HDL level. And so in my mind, it was, could this be MASLD? But like his ALT is incredibly high. So could there be something else going on? So we actually were contacted upfront by the primary, who said, look, this is a kind of a slightly odd case. The liver enzymes are really high. I would have normally said this is MASLD, but is there something else going on? So we started an initial workup. And just so you know, the patient was completely asymptomatic through all of this. When I met him in clinic, we reviewed some of these things. So he had some seasonal allergies, but really nothing else going on. Some antihistamines and nasal spray as needed, but no other medications that I could that in my mind meant that he was having like a drug-induced liver injury. He just had this snoring thing that was going on that he had a sleep study for, but no other medical issues. And there were no known GI or liver issues within the family. And importantly, no one else in the family with obesity or overweight. So his initial labs, as I mentioned, his ALT, AST were quite high to begin with. And then just so you know, the kind of these are all labs within the first month after that first presentation. So they started to come down, right? But they were still pretty high. So typically when I see patients with MASLD, I will have enzymes like hundreds, 200s, usually less than that. So 1,000, 1,000 ranges is pretty atypical. So importantly, his GGT was normal, his bilirubin was normal, and his CBC was looking fairly unremarkable. One of the main things we think about when we have really high liver enzymes is, could there be an infectious process? His CBC does not seem to support that. So just to kind of say that out loud. And then we got some imaging on him. So this is his actual liver ultrasound. I am no radiologist, but I will tell you that is not a nice looking liver, in the sense that, the shape of it is okay, but there's this sort of speckling to it, which is what we refer to as echogenicity of the liver. And that's often associated, it's not definitively diagnostic of steatosis, but is often the thing that we see when a patient has fat in their liver. He had otherwise no findings in his liver. His gallbladder looked normal, just has this sort of mild echogenicity. But then interestingly, his spleen was also notably enlarged on this study. So if you remember, I said when we're thinking about other causes, spleen being enlarged is actually not that common. So again, starting to sort of pique my interest of like, yes, this could be MASLD, but like, is there something else going on here? I ended up getting a liver biopsy on him, because when a hepatologist doesn't know the answer, we get a biopsy. So the biopsy, interestingly, showed severe fibrosis with what looked like almost a cirrhotic picture. So cirrhosis is where the fibrosis, the scarring is so bad that it's now formed little islands within the liver. And that's what we were looking at, actually, when we looked at his biopsy. But there was a significant steatosis also. So he had steatosis, fat in his liver across essentially all of the liver, and then some inflammation scattered throughout his liver also. So now it's, I think my hope is that all of you will be saying, oh my gosh, look for inborn errors of metabolism, because this is weird, right? So we kind of did what we sort of did. We did follow up, and and just to give you a sense, like every visit with him was very detailed. Like, what's the diet? What are the changes since the last visit? But we knew that, like in the follow-up visits, when his liver enzymes had already started to come down, he had made some good changes in terms of his exercise. He was eating smaller portions. He was trying to reduce juice intake. He had completely cut out soda and cola, because I had lectured him really hard about that, and was still asymptomatic. So now, in thinking about, could there be a zebra type situation going on here, I started to think about that a little bit. And I sort of, in formulating my assessment of this patient, I said, well, it does seem like there is some steatosis, right? And that there's a steatotic component to this disease, whatever this disease is. It was weird to have cirrhosis already. So anyone, I mean, he's 12 now, but the process had started when he was 10. And the fact that he already had cirrhosis on his biopsy was atypical. It's definitely not what we typically see in pediatric MASLD. And then the fact that his liver enzymes were so high at the beginning made this also feel a little bit different. I did send his lysosomal acid lipase level. That was normal. I did send him to genetics. This is, he actually has had a genetic workup, and weirdly enough, nothing has come up at all. His genetic testing is completely negative. We sent 24-hour urine copper looking for Wilson's disease. We did copper staining on his biopsies. We sent some extra stains on his biopsies. And I will tell you that nothing has come up at all. So where is he at now? Well, he has continued to gain weight, sadly. This was actually, I want to give him some credit for his recent improvement. So maybe about 4 months ago, he was still gaining weight despite diet and exercise modification. He was referred to our weight management clinic, and actually was, once he got on metformin to start with, his A1C was a little bit elevated, so he started him on metformin. When he was taking it consistently, he actually did lose weight. He is being referred for, or was referred for, a tonsillectomy because of sleep apnea. And why I mention this specifically is because we know that sleep apnea and sleep disordered breathing can contribute to the progression of fatty liver disease and steatotic liver disease. This is a very well-known fact in adults. There is some early data in pediatrics that this is a similar process. So when you have sleep apnea and MASLD, likely you will progress through it faster. And so this was, I think, particularly important in this patient's case. Sadly, they decided not to get a tonsillectomy, but I'm going to keep trying to convince them. And he was actually started on an antihypertensive for blood pressure also. These are his most recent lab trends, and there's a couple of things to sort of note here. I'll start with the ALT. So his ALT, starting the old ones at the bottom and the newer ones at the top. So his ALT is finally starting to improve. So we are finally starting to see some improvement. I suspect it's because he's taking metformin consistently, and he's been much better recently with his diet and exercise changes. I'll tell you, I think it's because he's now finally in counseling. I think that there was a significant depression and anxiety component in this particular patient, and getting psychotherapy on board for him has been helpful for him to then be able to participate in diet and exercise interventions. So that was key for him. The other thing is his HbA1c up and down a little bit. We're still working on that. We're still, I think, a work in progress. Triglycerides also up and down a little bit, down from his original presentation, but certainly still with some work to do. And then his platelets, why I've included his platelets in here is when you have a patient that has cirrhosis can develop into portal hypertension, which is basically a sort of end-stage version of liver disease. And I'm worried about that with this patient, actually, because of his biopsy showing pretty significant fibrosis and cirrhosis, but also now that he's developing slowly thrombocytopenia, progressive thrombocytopenia, which in the context of cirrhosis and portal hypertension in a patient with known splenomegaly is likely an indication that his portal hypertension is progressing, which is, again, very atypical. So that's just kind of where he's at right now. And just to kind of summarize this, his liver enzymes are improving. His lipid profile, A1C, seem to be worsening. He is getting, which is really nice for this patient, because of the fact that we're all worried about him, he's getting some pretty good multidisciplinary care with invested providers. So he has a very invested PCP. His weight and wellness clinic visits are frequent. He comes to see me frequently, and we all talk to each other quite a bit. And that is honestly, for me, what all patients should be getting. I'll not get on my soapbox about that for the moment, but certainly the close multidisciplinary follow-up is key for these patients, especially those who have advanced disease. He has a stable thrombocytopenia and hasn't had any bleeding complications so far, and has had no decompensating events related to his cirrhosis and portal hypertension. I am not sure where this is going to go, to be honest, in terms of whether his fibrosis will improve with his dietary modifications. I am thinking that he, in the next 6 to 12 months, I think if he's not consistently losing weight, or at least improving, it doesn't show continued improvement in his liver enzymes, we may be thinking about bariatric surgery referral for him. And ultimately, whether this patient ends up needing a liver transplantation remains to be seen. I think if he's at the point of cirrhosis on a biopsy, it is likely that he will proceed that way. I will say this is very atypical for us. So I think I chose this case because it's pediatric MASLD, but atypical in how quickly it's progressed and where it's ended up. And just to kind of talk you through the fact that when you have these odd features, that it should drive you to kind of think about these other genetic and other factors and other diagnoses. But in this case, I think I've come to the conclusion that it likely is just MASLD with contributing factors being sleep apnea, interrupted care, and difficulty with dietary and lifestyle modification related to mental health, and that it has just progressed quickly. And so we will see what happens. I wanted to just give a special shout out to my very wonderful fellow, Dr. Brichta. She is out because she just had a baby, a very lovely, beautiful baby. Many congratulations to her, but she did a lot of the work for this presentation and deserves a lot of the credit. And here are some references. I definitely would encourage folks to read the ASLD statement guideline. It's very helpful for the management of pediatric MASLD. And I will be happy to take any questions.
Yes, I'm going to thank you, Dr. Batul Kaj, for your presentation. I'm going to start sharing my screen, and it'll have the questions, the question slide as well.
Sounds good.
Okay. Yeah, if anybody has any questions, feel free to drop them in the chat, or you can raise your hand. Dr. Batul will address them now. I'll give it a minute to see if there are any questions.
I feel like maybe it's so straightforward to everyone that they have no questions and they're going to be expertly managing pediatric MASLD for the rest of their careers. That will be great.
Okay, I'm going to assume there are no questions because nobody's raised their hand and I don't see any in the chat. So, before we go, this concludes the 2025 Liver Health Echo series presented by the American Liver Foundation in partnership with Project Echo. Thank you to everyone who has attended and participated. There's also a QR code at the bottom here for you to learn more about each session and to give your thoughts as well. So please scan it and share your thoughts. And finally, a heartfelt thank you to our program sponsors, 89Bio and Behringer Ingelheim, for generously supporting American Liver Foundation's 2025 Liver Health Echo Sessions. Thank you all, and that's the conclusion of our presentation.